Okay, good afternoon, everybody. I see that it's 2 o'clock. So just before we get started with Dr. Bhanot, this is our first meeting since the first exam. The first exam's obviously in the books now. I am going to talk about the first exam today, but I'm not going to talk about it right now. I'm going to let Dr. Bhanot give her lecture. I'm giving the second lecture, so I'll spend probably 5 minutes or so discussing the exam at the beginning of my lecture. Okay, and we'll just talk about, I'll give you the stats and what give you a better sense of what your scores mean and where you stand in the course at this point in time. I will say that I have not released the grades into the grade. I put them in the grade book, but I haven't released them yet. And the only reason for that is that the grade book is being upgraded at the moment. There was a lot of students sort of join and drop the course after the course started. So the grade books are kind of they say there's some students in there that shouldn't be in there, and there's some students that shouldn't be in there who are not in there, and that's all my understanding is that's all going to be corrected today. So as soon as I've got that roster corrected in there, I will release the grades into the education management system, which is where we're keeping the grade book for the course. And I'll ask you then to go in at that point and check your grades, because they do have to be, I do have to enter them manually. I do double and triple check them, but on occasion I do enter a grade incorrectly. So it's always good for you to go in and make sure that the grade corresponds with what you recall your grade being when you exited the exam. Okay, and I'm always happy to go back and double check against ExamSoft for anybody who wants me to do that. So that's all I'll say. As I say, I will talk about the exam, but later in the session after Dr. Bhanot's lecture. So I'll turn it over to you, Purnima.
Okay, thank you, Ian. So welcome to the lecture on bacterial diseases of the CNS. So this is the first slide showing what a bacterial disease of the CNS can do to the brain. So on your left is a normal brain, and on the right is the brain of a patient who died from meningitis caused by Streptococcus pneumonia. And what you can see, this white matter is pus, and there's a lot of hemorrhaging in the brain. So this is just a graphic way to show you that bacterial infection of the CNS is a very dangerous outcome. So now the bacterial disease that we'll be focusing on is meningitis. And as the name implies, meningitis is inflammation of the three membranes that cover the brain and the spine, the meninges. It is not infection of the underlying brain tissue. Now that happens in a different disease that's called encephalitis. In meningitis, however, it is only the membranes that are infected and inflamed. Now, meningitis can be caused not only by bacterial pathogens, but also by viral pathogens. And these are the two most common causes of meningitis. There are other less common causes, such as fungi and even nematodes, and I'll touch upon them very briefly right at the end. For today's lecture, we are going to focus exclusively on bacterial meningitis. Now, when a person presents with symptoms consistent with meningitis, it is imperative to diagnose whether it is bacterial or viral in nature, because although the symptoms look the same, the outcomes are very different. Viral meningitis, for example, often resolves on its own and is rarely fatal. On the other hand, bacterial meningitis is very dangerous, and if left untreated, is almost always fatal, and even when treated, can have some really serious after effects. So what are the signs and symptoms that could indicate meningitis? So for anyone who is not an infant, so above the age of 2, the most common symptoms of meningitis are a very high fever, and a really awful headache. Often, very, very commonly, you also have rigidity of the neck, and this is what is called nuchal rigidity. And it occurs because when you bend your neck, when you move your neck, it flexes the spine, and this stretches the meninges, which are, of course, inflamed in meningitis. And so moving your neck is uncomfortable. Less commonly seen symptoms are things like vomiting. The person is confused or lethargic and sleepy. They might also experience seizures and have a sensitivity to light, and which is called photophobia in the literature. If not treated, it can result in coma and death within hours. So diagnosis of bacterial meningitis, or bacteria being the cause of meningitis, is really important. Now, in infants, so babies are below the age of 2, these classic symptoms that we see in older children or in adults are missing. And instead, the symptoms are rather non-specific, which makes it a challenge to diagnose this. So babies with meningitis are often lethargic. They cry more, so they're irritable. They don't eat so well, or they vomit. And unfortunately, all of these symptoms are seen in babies commonly. Babies often cry and often don't feed right. So this can be a challenge to detect that they have meningitis. Now, if meningitis is suspected, the most important thing to do is to determine the cause of that meningitis. Is it bacterial or viral in nature? So this differential diagnosis is achieved by examining the cerebrospinal fluid that you obtain through a lumbar puncture of the patient. And you take some of the cerebrospinal fluid that you collect, and you examine it using gram stain to see if you can detect any bacteria. Now, as you know, not all bacteria can be detected using gram staining. So the absence of gram-stained bacteria doesn't necessarily mean that bacteria are absent. So you have a number of other criteria to consider as well. One of them is what type of white blood cells are being found in the CSF, and what numbers are they present in. You also look at the glucose concentration of the CSF as compared to the blood, and you same thing for protein levels, because as you'll see in a minute, glucose levels and protein levels in CSF are different when it is bacterial meningitis compared to viral meningitis. And then finally, if bacterial meningitis has been determined, then the specific species of bacteria responsible for the meningitis and the specific strain can be determined using a latex beta-glutination assay. And then finally, for confirmation of these CSF results, we try to culture the bacteria both from the CSF and the blood. And that would be a confirmation of the cause. Now, what does a CSF analysis look like in the case of a bacterial or viral infection? Now, both viruses and bacteria lead to an elevation in the number of white blood cells present in the CSF. But this elevation is much more dramatic when it's a bacterial infection compared to when it's a viral infection. The type of white blood cells that are found in CSF fluid are also different. In the case of bacterial infections, you encounter PMNs, whereas in viral infection, you most likely encounter lymphocytes in the CSF. Importantly, glucose levels in the CSF are reduced compared to the blood if it's a bacterial infection, because the bacteria are using the glucose in CSF and converting it to lactate, whereas viruses, because they're intracellular and are replicate within the host cell, don't alter the glucose levels of CSF. So glucose levels will appear normal in viral meningitis, but be reduced in bacterial meningitis. And by the same token, lactate will be elevated in bacterial meningitis and continue to be normal in viral meningitis. Another thing that is elevated in significantly when it is a bacterial infection is protein levels in the CSF. Bacterial pathogens lead to the leakage of proteins into the cerebrospinal fluid. So these are the features of differential analysis that allow for a preliminary diagnosis of bacterial versus viral infection. If it is bacterial infection, then you need to treat aggressively, and exactly what antibiotics you use depends on the bacteria that are causing the disease, and we'll go through this in the rest of the lecture. So what are the main causes of bacterial meningitis? A number of bacteria can lead to meningitis, and the epidemiology of the disease is determined by the age group of the patient. So for example, in newborns, the most common causes are strep B, so group B, streptococcus, E. coli, or Listeria monocytogenes. These are bacteria that are encountered by newborns as they come out of the birth canal. In slightly older children, so infants and maybe for a few years of age, the most common causes are Streptococcus pneumoniae, Neisseria meningitis, and Haemophilus influenza type B. Now I have a red star next to Haemophilus influenza because this was a major cause. This was the primary cause of meningitis in children until the introduction of a very effective vaccine. And in countries where the uptake of this vaccine is high, Haemophilus influenza has been largely eliminated as a cause of meningitis in those countries. Now, in still older adults, so adolescents and young adults, till the age of 65, for instance, Neisseria meningitis and Streptococcus pneumoniae continue to be problems. In older adults, so about the age of 65, for example, are susceptible to Streptococcus pneumoniae, Neisseria meningitis, just like younger adults, but now they also face a difficulty from Listeria monocytogenes once again. So this is this slide is simply summarizing what I just told you, which is the causes of childhood and adult bacterial meningitis. The major causes are different in the different age groups. Now, one thing all these bacterial pathogens have in common, the ones that cause meningitis, so Neisseria meningitis, Haemophilus influenza, and Streptococcus pneumoniae, have some properties in common that make them pathogenic in this fashion. So they all have capsules around them. So, and these capsules help in their virulence because they prevent phagocytosis of bacteria by immune cells. So, and in addition to having this anti-phagocytic capsule, they have other properties that are defined sort of non-specifically and amorphously under this catch-all term, meaning serum resistance. And this is just a way of saying that for a variety of reasons, these bacteria are resistant to the host immune response. Now, the presence of the capsule is really important because although not all capsulated bacteria cause disease, disease is rarely caused by bacteria that do not have a capsule. So for the next several slides, I'm going to go through each of these major bacterial pathogens that I mentioned and talk about their role in causing meningitis. So Neisseria meningitis, as you know, as we just mentioned, is a major cause. I'm sorry, I skipped ahead here. Is a major cause of meningitis in young and older adults. This is a gram-negative diplococcus, and it is interestingly part of the normal flora of the nasopharynx in almost 10% of the population. So it's present in the nasal cavity of 10% of adults, but doesn't cause disease unless it leaves the nasopharynx, enters the bloodstream, and then is able to cross the blood-brain barrier to infect the meninges of the brain and cause meningitis. Now, Neisseria meningitis have a capsule, and the capsules have at least have more than 15 distinct antigenic structures. But out of these more than 15, disease is associated with 5 capsules. So 5 capsules cause Neisseria meningitis meningitis. And just to show you how common this of Neisseria meningitis is in the nasopharynx, well over half of all adults, so in some cases as high as 90% of all adults have protective antibodies against at least one or more types of Neisseria meningitis. So in many cases, many of these capsulated Neisseria meningitis are fought off effectively by the immune system. We have protective antibodies against them, but these 5 capsule types, A, B, C, Y, and W135, are a little bit harder to control and are associated with disease in meningitis disease. So once again, Once again, the virulence factors of Neisseria meningitis are its capsule that prevents phagocytosis by immune cells. It also encodes a protease that chews up the immunoglobulins that the host makes, and this prevents, by chewing up the immunoglobulins, it prevents adhesion of the phagocytic cell. The bacteria itself have villi that allow it to attach well to host cells and enter the host cells. Now the LPS, the capsule of these bacteria, consists of an unusual polysaccharide, LOS for short, it's lipo-oligosaccharide. And this is highly endotoxic, often has sialic acid on it, and is associated with virulence. Now, Neisseria meningitis causes bacteremia in the blood. This is known as meningococcemia, in addition to meningitis. Some additional distinctive features of meningitis caused by Neisseria is the appearance of this kind of skin rash, known as petechial rash, and if it's large in size, they're called purpura. And these are nothing but hemorrhages in the skin as a result of the endotoxin that Neisseria carries. Another common feature of Neisseria infection is known as Waterhouse-Friderichsen syndrome, and this is a massive hemorrhaging and death, necrosis of the adrenal glands. Now, Neisseria meningitis, even when cured, can lead to long-term hearing loss and mental retardation. And this is an example of the long-term sequelae that I had mentioned at the beginning of my lecture. Now, in order to diagnose Neisseria meningitis, you look at a gram stain of CSF, and Neisseria meningitis will appear as gram-negative diplococcus on these gram stains. You can, for culturing, It cultures well on chocolate agar in the presence of 5% carbon dioxide. The colonies are small in size and they are positive for oxidase. Another useful test to tell Neisseria meningitis apart from another Neisseria species, Neisseria gonorrhea, is a fermentation test. So both Neisseria gonorrhea and Neisseria meningitis will ferment, will grow on glucose, but only Neisseria meningitis is able to use maltose as a carbon source. And then finally, once you have determined that Neisseria meningitis is the bacterial pathogen, you want to determine, well, does it have, is it one of those 5 pathogenic capsule types? And if so, which of the 5 is it? You do an agglutination test using latex beads that have antibodies against each individual capsule. And so if the bacteria in question has expresses the capsule type for which the beads have an antibody, then the beads will agglutinate as shown here in this photo on the left. And then this is how you will determine whether it's type A, B, C, Y, or W135. Now, the epidemiology of Neisseria meningitis is that it is transmitted by respiratory secretions, so coughing, cold, and most cases are sporadic. However, there are outbreaks or epidemics within populations that are closed, so a high concentration of people in a small amount of space, for example, in military barracks or in college dorms. And residence in military barracks and dorms leads to a really high, significantly higher proportion of carriers in the population. So at the beginning of living together in close quarters, maybe only 5 to 10% of the population has Neisseria meningitis as part of their normal flora of the nasopharynx. But after living in these situations, that number goes up to 70 or 80% of people. Now, in addition to these closed populations experiencing outbreaks, there is also a region of sub-Saharan Africa shown here in this map of Africa, and this belt in orange experiences Neisseria meningitis outbreaks about approximately once every 10 years and is known as the meningitis belt. Now, certain genetic factors increase a person's susceptibility to Neisseria meningitis. And this is, some of these factors are identified. So for example, defects in the terminal, in the complement system of the host increases the incidence of infection. Now, newborns are generally resistant to Neisseria meningitis because they still have maternal antibodies. However, as they grow older, they lose these maternal antibodies, but are not yet old enough to have a robust immune system of their own. And so young children are at particular risk of Neisseria meningitis. It's the gap between losing the maternal antibodies, but not yet producing your own. Neisseria meningitis is susceptible to a variety of antibiotics. So you can treat it using a bunch of penicillins, for example. In order to, you also want to preemptively preempt Neisseria meningitis infection. And so carriers or close contacts of meningitis patients are prescribed rifampin or ciprofloxacin for chemoprophylaxis. Another great way of preventing meningitis is vaccination. So there are, I think, 2 different vaccines available at this point for Neisseria meningitis. The first one recognizes 4 of the 5 virulent types, and this is required by the military and is recommended in college terms, and some colleges even require it as a condition for students living in college terms. There is now a second vaccine available that recognizes group B Neisseria meningitis. And I believe this this vaccine now is incorporated, is now a pentavalent vaccine. So a single vaccine can recognize all 5 of the disease-causing Neisseria meningitis strains.
Dr. Bhanot, there's a question in the chat.
Okay.
It says, although it is difficult to detect meningitis in infants, once diagnosed, is the long-term effects of the disease less severe than in an adult?
I don't think so. The long-term sequelae would be similar to an adult. Okay. Any other questions? Any other questions, Ian? I can't see the chat.
It looks like there's a question from much earlier, but and that was, I think somebody was asking about examination of the cerebrospinal fluid, and what about the protein levels in viral infections?
So I think that's part of the chart that I showed earlier.
Okay.
So Ian, would it make sense to perhaps hold these questions to the end, or?
Yeah, that's right. I was going to leave that till the end, but I thought this might be a good place to cover this, because we could go back to the slide at that point.
Sure.
There's one more question just came in. Are the virulence factors for all meningitis?
I'm sorry, can you repeat the question?
Is the virulence factors for all meningitis?
I don't understand the question.
Yeah, I don't either. Delina, do you want to unmute and clarify, please?
Oh, no, there was a slide on virulence factors, and I was wondering if, because we were talking about Neisseria, so I was like, is this only for Neisseria, or is it for like all the other meningitis? Yeah,
so
like,
are you talking of this particular slide?
Yeah.
This is yes. So these are virulence factors of Neisseria meningitis.
Okay, yeah, I was wondering if it was also for the other ones, but okay, thank you.
Sure. And since we're going back so let me just go back here and to the question about protein levels in viral meningitis. So you can see it on this chart that viral meningitis can cause a slight elevation, so about 100. But bacterial meningitis, the elevation is much more dramatic. So there's a little bit of an overlap, but bacterial meningitis will have in general, will have dramatically increased protein levels, and also importantly, reduced glucose and elevated lactate. So I hope that answers the question.
So you're basically saying that the level of viral protein is basically insignificant?
No, I'm not saying viral protein. I am talking of protein levels in CSF observed during viral infection. That is not, I'm not saying this protein is not viral protein or bacterial protein. This is general level of host proteins found in CSF.
Okay.
Any other questions? Okay. So let's move on to Haemophilus influenza. So Haemophilus influenza is a gram-negative Coccobacillus, also with a capsule. We've been talking about this. It's also part of the normal flora of the nasopharynx. Haemophilus that does not have capsules are found in almost, at least 35 to 90% of the population. Carries some kind of Haemophilus influenza. Now, there are, in terms of antigenic structures, Haemophilus influenza has 6 different capsule types, and these are labeled A, B, C to all the way to F. But the primary virulence comes from a single capsule type, and this is type B. So type B Haemophilus influenza causes 90% of meningitis that is attributed to Haemophilus influenza. The capsule consists of polyribosyl ribitol phosphate. And again, this is anti-phagocytic in nature, contributes to the virulence of this bacteria. And as mentioned earlier, Haemophilus influenza that do not have capsules rarely cause any kind of disease. Now, similar to Neisseria meningitis, you can have bacterial infection in the blood in addition to meningitis. And you can also get conjunctivitis from Haemophilus influenza and a disease called croup, which is inflammation of the epiglottis. So you have trouble swallowing, for example. It also is a significant cause of pneumonia and of otitis media, which is a middle ear infection. And in fact, is second only to strep pneumonia as a cause of pneumonia. The sequelae of infection of long-term sequelae of a Haemophilus influenza infection are similar to Neisseria meningitis, which are things like mental retardation that I mentioned before. Diagnosis is once again done using gram staining of CSF. These bacteria like to grow on chocolate agar and in the presence of 5% carbon dioxide. The colonies will be large and flat and sort of grayish in color, and their growth requires the presence of two factors called factors X and factor 5, which are nothing but hemoglobin and NAD or NADP. And in the presence of both of these factors, the bacteria grows really well. In order to determine whether it's type B or another kind of capsule type, again, one has to perform latex agglutination assays. Like with other bacteria of the nasopharynx, transmission of Haemophilus influenza is through respiratory secretion. Most cases are sporadic and occur in children. At one point, type B Haemophilus influenza accounted for 98% of all Haemophilus influenza meningitis in children below the age of 2 years. And this in the US meant almost 12,000 cases a year. Now, with the introduction of a Hep B vaccine, this number has been reduced to 300 cases. So from 12,000, it's down to just 300 cases a year. And about half of these cases result from Haemophilus influenza type B. And these might be children who have not been vaccinated, or maybe they were too young to receive a vaccine. And so in this small population remains susceptible to type B Haemophilus influenza. Treatment, once again, is using antibiotics. Close contacts receive chemoprophylaxis if they've been in close contact with the patient. Once again, the conjugate vaccine to type B is given to children older than 2 months and is highly protective. And the protection delivered by the vaccine is something you can see in this chart. So in green is meningitis caused by Haemophilus influenza, and in red are serious disease caused by Haemophilus influenza. As you might remember from a couple of slides ago, meningitis is not the only manifestation of Haemophilus influenza infection. So both serious disease and meningitis from Haemophilus influenza type B decreased immediately after a vaccine was introduced and was taken up in the population. Both these cases declined very significantly and stayed low for a number of years. But then, as often happens, once a disease becomes less prevalent because of the use of a vaccine, we get complacent, vaccine use goes down. And when that happens, the cases of serious disease and also of meningitis started to rise up once more. So in the early 2000s, there was, So in the early 2000s, there was a second campaign for a Hep B vaccine uptake to make sure that these cases did not continue to climb. The third major cause of meningitis is Streptococcus pneumonia. This is a gram-positive, lancet, long-shaped diplococci. It leads to alpha hemolytic colonies, so they lyse hemoglobin to some extent. Once again, it is a part of the normal flora of the nasopharynx in sometimes as much as 70% of the population. Now, unlike Haemophilus influenza, the antigenic structure of Streptococcus is very complicated. There are at least 85 capsule types, and out of these 85, 23 out of these 85 are responsible for the vast majority of the disease. And once again, if you a Streptococcus pneumonia that do not have a capsule either cause no disease at all or very mild disease. So in addition to meningitis, Streptococcus pneumonia can cause lobar pneumonia. So it's a major cause of bacterial pneumonia, and also a middle ear infection called otitis media. Amongst young children and young adults, Streptococcus pneumonia is the major cause of meningitis, and the same kind of sequelae as for Neisseria meningitis. The gram stain of CSF is used to detect Streptococcus pneumonia. The colonies are small and grayish in color. They cause alpha hemolysis. They're also bile soluble, and they are sensitive to this chemical called optogen. To determine whether the strep is sensitive to penicillin or not, clinical microbiology labs will use a disc screen using oxacillin to determine sensitivity to penicillins. Now, commonly, strep pneumonia is seen in winter and in spring, mostly when our noses are running, lots of respiratory secretions. Now, strep pneumonia, importantly, is also associated with trauma to the head. So having a head injury can enable the bacteria to get out of its normal zone of the nasopharynx, enter the blood, and enter the meninges and infect them. In the US, strep pneumonia has overtaken Haemophilus influenza as a cause of meningitis, and that's because the Hep B vaccine has suppressed pneumonia, pneumonia and meningitis caused by Haemophilus influenza. Now, people who are immunocompromised, so for example, they lack a spleen or have a damaged spleen because of sickle cell anemia, are at increased risk of Streptococcus pneumonia. Also, people with defects in humoral immunity or alcoholics also have reduced immunity and are at higher risk of Streptococcus pneumonia. Treatment is with penicillins as long as the type is sensitive. For prophylaxis, we rely once again on vaccines. A vaccine known as Pneumovax is protective against a variety of capsule types. A second vaccine, and this is given to individuals who are at high risk, either because of asplenia, sickle cell anemia, or the elderly. There is a second vaccine, a conjugate vaccine that conjugates the capsule to a protein antigen, and thereby elicits a stronger immune response, was introduced about 20 years ago, and it is approved for use in young children, so children below the age of 2 who are also at increased risk of strep pneumonia infection. As I mentioned at the beginning, pneumonia in young children, in infants, can be hard to diagnose because the symptoms are so non-specific. And yet it is very, very dangerous for infants. Now, the causes of neonatal meningitis are a bit different from adults, because as the newborn is coming out of the birth canal, it is exposed to the flora of the mother. And amongst these flora, for example, can be Streptococcus agalacticae, or GBS. This is found in 25 to 40% of all women as part of the normal flora. If it infects the newborn, it can manifest either as within the first week of birth. This is known as early onset, or in the other bump-in cases of Streptococcus galacticae meningitis occur within the first 12 weeks, so the first 3 months of birth. This is seen, it's not that common, it's 1 to 3 cases every 1,000 births. However, the mortality rate is very high, so anywhere from 30 to 60% of infections lead to death, and hence the concern for neonatal meningitis. So this is a slide that I took from the CDC that provides some numbers on the maternal to infant transmission of Streptococcus agalacticae. So if the mother is colonized by GBS, so GBS is part of her normal flora, then she has about a 50-50 chance of passing it along to the newborn. Now, if the newborn becomes colonized, the vast majority of them, 98% of them, are going to be totally fine. They're going to be asymptomatic. However, in about 2% of the colonized newborns, you might see early onset bacteremia in the blood, or pneumonia and meningitis. And this is where the danger lies. If a newborn is thought to have meningitis, the diagnosis is via a agglutination test looking for group B, Streptococcus agalacticae. The baby is given penicillin, and the other way to prevent it is by giving the mother prophylaxis with penicillin either during labor, and this is done, the reason it's done during labor is because if the mother is treated prior to labor, then by the time labor comes around, she's going to be colonized once more. So it would not be useful. And so mothers who are at risk of Streptococcus agalacticae, for example, they have a history of meningitis, or they had tested in various prenatal exams, had tested positive for GBS in a vaginal or rectal exam. So these mothers would be given, during their labor, would be given penicillin to reduce the risk of transmission to the newborn. Another bacterial pathogen that is a cause of neonatal meningitis is this bacterial Listeria monocytogenes. It's a gram-positive bacteria. And interestingly, this bacteria prefers growth at low temperatures, so at 4 degrees rather than a warmer temperature of like 37. It shows a motility called tumbling motility. And there are actually some fun YouTube videos where you can see some videos of this tumbling motility. It really is the bacteria sort of tumbling end over end. And this motility is seen once again at like a lower temperature, so at seen specifically at 21 degrees, but the bacteria will not be motile at a higher temperature of 37. This can be manifested both as early and late onset neonatal meningitis, and is a particularly important cause of meningitis in immunosuppressed individuals. Once again, treatment is through penicillins. Now, E. coli of a particular strain, K1, is the major cause, is also a cause of neonatal meningitis. And this strain, this K1 strain, is the cause of 80% of E. coli caused neonatal bacteremia and meningitis. In addition, there are Staphylococcus aureus, Enterococcus also can cause neonatal meningitis. These are all bacterial species that are part of the normal flora, but in some cases can turn pathogenic. Another group of patients where meningitis is encountered more often are ones that have undergone a brain shunt procedure. So this is an intracranial shunt is put in order to relieve intracranial pressure in the skull. But if surgery does not go so well, these shunts can become infected, most commonly by bacteria that are part of the normal skin flora. So during the surgical procedure, these bacteria that otherwise live harmlessly on the skin gain access to the shunt and to the meninges or to brain tissue and cause meningitis. And so examples of these are Staphylococcus aureus is the major example, but also gram-negative rods, Enterococci, corynebacteria, even fungi like Candida can cause meningitis in shunt infections. And then finally, this is in my last slide here, just is a list of some of the other less commonly encountered causes of meningitis. So these are slow-growing agents. They don't cause acute disease. It's more chronic meningitis. This can result from the bacteria that causes tuberculosis, so Mycobacterium tuberculosis. In immunosuppressed patients often have fungal infections from Streptococcus neoformans that can cause disease. The coccidiosis, histoplasma, blastomyces, and Candida are all different fungal pathogens that can lead to meningitis. And another bacterial agent is the agent for Lyme disease, Borrelia burgdorferi, can also lead to chronic meningitis. As can cysts of the tapeworm cause T. solium. I forget what the T stands for. It's a long word that I don't remember at the moment, but the common name is tapeworm, and cysts of the tapeworm in the brain can also lead to meningitis. Okay, I think that brings me to the end of this lecture, and I'm happy to take questions at this point. Okay.
Anybody else wants to ask a question, please feel free to unmute and ask the question if you like. Purnima, it looks to me like you actually are recording, and it may have been because I made you co-host when I started recording. Maybe that automatically starts you recording.
Ah, I see. Okay. All right.
Do you have a stop recording function on your?
Yes, I do.
All right.
Should I stop now?
You might as well.
I have a stop and a pause, but no start.
All right. No, you can go ahead and stop recording if you like.
Great.
All right. So for the rest of the students, it is